Good morning. I'm Dr. Veronica Gillispie-Bell, and I'm the Medical Director of the Louisiana Pregnancy-Associated Mortality Review. Today, I'm going to be sharing the findings of our 2020 PAMR report. Okay, let's get started. So when we think about the mortality review and the process that we've had in Louisiana, we published our first report reviewing deaths in 2008. We published our next report reviewing deaths from 2011 to 2016. This was a much more expedited review. We only reviewed deaths up to 42 days after pregnancy and only from causes related to the pregnancy. Beginning with our 2017 report, we began reviewing deaths that were defined as the death of an individual at the time of pregnancy up to 1 year of the end of pregnancy. We also included review of deaths from all causes, and that currently is the way up to this day that we still review maternal mortality. So who is the PAMR committee? The PAMR committee is a group of individuals that are all coming together to review all maternal deaths. And again, that is defined as the death of an individual while pregnant or within 1 year of the end of pregnancy, regardless of the cause. We work to understand the drivers of maternal mortality, the complications of pregnancy, and understand where we have disparities. And probably most importantly, we determine where we can make interventions at the level of individuals, families, providers, birthing facilities, health systems, and communities. And then we inform the implementation of initiatives. So for the review process, so the way we identify maternal deaths is through the death certificate. In 2003, the death certificate nationally was updated to include a pregnancy checkbox. So we identify deaths as those that are on the death certificate, or that have a death certificate and have the pregnancy checkbox indicated or marked. We then go through the process of confirming, was that truly a pregnancy-associated death? So for our 2020 deaths, there were 110 cases identified, 82 were confirmed, and 28 false cases. So 28 cases where the pregnancy checkbox was marked, but possibly that patient or that individual, once we reviewed medical records, was actually not pregnant or within 1 year of the end of pregnancy. So after we confirm our cases, our maternal child health coordinators gather all of the information through abstraction for us to then begin reviewing those deaths. They will gather medical records, coroner's reports, in some cases police reports, and they do all this to create a case narrative. And then as a review committee, we review those maternal deaths, asking several important questions. We first want to determine, was the death related to pregnancy? And we're going to go over some definitions in the next slide as to what that actually means related to pregnancy. We want to know what was the underlying cause of death. We want to know if the death was preventable. Was there any chance to alter the outcome? And we want to identify the factors that contributed to the death. And then finally, what specific and feasible actions could we have taken to change the course of the events? And that's how we generate our recommendations. Now, our review committee is not a bunch of medical doctors sitting in a room looking at medical records. In fact, our review committee is half clinical, half non-clinical. So yes, we do have physicians, we have OBGYNs, we have maternal fetal medicine specialists, but we also have addiction specialists, we have domestic violence specialists, we have a patient. We have doulas, we have midwives. So we really are sitting down and doing a multidisciplinary review to better understand what is driving maternal mortality and where we can make changes for prevention. I mentioned that one of the goals of the committee is to determine if the death was related to pregnancy. So let's talk about those definitions. So we can think about pregnancy-associated deaths as the big umbrella. So that's the death of an individual during pregnancy or up to 1 year of the end of pregnancy. From that big umbrella, we then categorize the deaths as being pregnancy-related, pregnancy-associated but not related, or pregnancy-associated and unable to determine relatedness. So a pregnancy-related death is the death of an individual, again, during pregnancy up to 1 year of the end of pregnancy, but the death occurred from a pregnancy complication, a chain of events initiated by pregnancy, or the aggravation of an unrelated condition by the physiologic effects of pregnancy. Commonly, we use the example of preeclampsia. If we have a woman that experiences a stroke because of preeclampsia, we would consider that to be pregnancy related because preeclampsia can only occur during pregnancy. Next, we have pregnancy associated but not related. So that's the death of an individual, again, at the time of pregnancy up to 1 year of the end of pregnancy, but they died from a condition that had nothing to do with the pregnancy. The example we commonly use is a motor vehicle collision. And then finally, we have pregnancy associated but unable to determine relatedness. So this is a death of an individual at the time of pregnancy up to 1 year of the end of pregnancy, but we're not able to determine based on the information that we have if that death was actually pregnancy related or not. Over the years, we have developed a few review tools to help us answer that question. One important review tool is the Utah tool, and yes, it comes from Utah. We adopted this tool to help us in determining if a death from accidental overdose or suicide is related to the pregnancy. If you look at our previous reports, you can see that we had a larger number of those pregnancy-associated but unable to determine relatedness deaths, and many of those were accidental overdose or suicide, and we were not able to determine at that time, for example, did that individual have existing depression that was then made worse by the pregnancy that would have then made it a pregnancy-related death? We just didn't have that information. So with the Utah tool, we provide this to our case abstractors. They look in the medical record for certain things that would indicate there was something about the pregnancy that worsened a condition that led to suicide or accidental overdose. And that, in fact, would then make that death pregnancy-related. The other tool that we developed is the Louisiana Bias or Racism and Social Determinants of Health, or the LABORS tool. So before our review process, we're given a tool from the CDC called Maria. Maria is a standardized way that all maternal mortality review committees review their maternal deaths. A couple of years ago, the CDC updated the Maria tool to indicate a bias or discrimination checkbox, meaning, did we feel that bias or discrimination occur? Did it occur in that care of that patient that may have led to the death? As you can imagine, that's really difficult to determine from medical records if bias or discrimination occurred. However, with this tool, we have identified certain things that we ask our abstractors to look for in the medical record that might indicate bias or discrimination. Now, just because we find those things in the medical record, it doesn't always mean that bias or discrimination has occurred, but it helps us as a committee to understand, to pose that question, and then have some evidence to support if we do feel like bias or discrimination may have occurred. The other parts of the LABORS tool are the demographics, social determinants of health, and the geospatial social determinants of health. We do know that 80% of our clinical outcomes are due to social factors. So this allows us as a committee to examine the social factors around that individual's life in their environment that may have contributed to their death, so that we can make more broad-reaching recommendations that will address social determinants of health. So let's move to the key findings from our 2020 report. So if we look at the snapshot of pregnancy-associated deaths, in 2020, we had 82 confirmed pregnancy-associated deaths. That gives us a pregnancy-associated mortality ratio of 144.8 deaths per 100,000 births. If we look at the raw numbers, 15 of those deaths were pregnancy-related, 64 were pregnancy-associated but not related, and 3 deaths were pregnancy-associated but unable to determine relatedness. And so we'll look at that in a little bit more detail. If we look at the causes of death, and this is looking at all causes, so the pregnancy-associated number, pregnancy-related, pregnancy-associated but not related, and then unable to determine relatedness, you'll see that the overall leading cause of pregnancy-associated deaths was accidental overdose, followed by homicide and then infection. So looking at that in a different way, again, pregnancy-associated deaths, the leading cause was accidental overdose. There were 28 deaths due to accidental overdose, 10 due to homicide, 8 due to infections. Looking at just pregnancy-related deaths, 4 were due to cardiomyopathy, which was the leading cause, 3 were due to cardiovascular conditions, 3 due to infection, and 3 were due to accidental overdose. So we're going to look at that in even more detail. So pregnancy-related deaths. I think this is very important. 94% of those pregnancy-related deaths were deemed by the review committee to be preventable. That means if there was any chance, even if it was just some, that we could have altered the outcome. And so again, 94% of those pregnancy-related deaths were deemed to be preventable. If we look at other contributing factors, in the pregnancy-related deaths, obesity contributed to 47% of those deaths. Mental health conditions contributed to 20%, and substance use disorder contributed to 27%. Now, from a epidemiological standpoint, a biostatistical standpoint, we have to be careful with those percentages because the count is less than 20. Again, we had 15 pregnancy-related deaths. And so it is difficult from the percentages standpoint to be statistically sound. So if we look at pregnancy-associated but not related deaths, our top causes were accidental overdose, homicide, motor vehicle collisions, followed by cancer. Of those deaths, again, pregnancy-associated but not related, 80% were deemed to be preventable. Looking at other contributing factors, obesity contributed in 8% of those deaths, mental health conditions contributed in 14%, and substance use disorder contributed to 44% of those deaths. Again, that's important when we think about those recommendations that we're making for different conditions and situations that we should be intervening. Now looking at demographics, much like the United States, the entire United States, we see disparities. So in 2020, 37% of all births in Louisiana were to non-Hispanic Black women. However, 62% of all pregnancy-associated deaths were to Black women. And if we just look at pregnancy-related deaths, remember there were 15 pregnancy-related deaths, 13 of the 15 pregnancy-related deaths were to Black women. Again, we have to be careful with the rates and ratios because our counts are less than 20, but it's hard to ignore the fact that 13 of the 15 deaths were to Black women. If we look at insurance type, we actually don't see disparities, but we see an opportunity. 61% of the births in 2020 were to women that were insured through Medicaid. 60% of the deaths were to women insured by Medicaid. So again, this isn't a disparity, but it's an opportunity. The majority of our births are covered by Medicaid. And so that provides us a system that is a unifying system where we can implement some of the recommendations generated by the committee. Looking at education, we also see disparities. So women with a high school diploma, GED or less, accounted for 72% of all pregnancy-associated deaths, but only 48% of the births. And so as we think about social determinants of health and those social demographic factors, we have to think about education as possibly a risk factor for maternal mortality. Moving to timing of death. Again, I think this is very important. If we look at just our pregnancy-related deaths, the majority of deaths occurred from the time of delivery up to 42 days after pregnancy at 53%. 40% occurred from 43 days up to 1 year. That means that 93% of the pregnancy-related deaths occurred after delivery up to 1 year postpartum. And that's really important when we think about, again, where we're making recommendations, when we're making those interventions. For the most part, this is when our patients are the most disconnected from care after they have delivered and up to 1 year postpartum, but specifically in that first 6 weeks. If we look at timing of death for pregnancy-associated but not related deaths, the majority of deaths occurred at 43 days up to 1 year postpartum. That accounted for 66% of the death, although 30% did occur while pregnant. So for those deaths that occurred from 43 days up to 1 year postpartum, the leading cause was accidental overdose. And for those that occurred during pregnancy, the most frequent causes were homicide and motor vehicle collisions. Now, moving to contributing factors, and there's more information that I'm going to give you, but you need to understand the definitions to understand this information as well. So these are definitions that are given to us by the CDC. But when we say contributing factors at the level of patient and family, we mean an individual before, during, or after a pregnancy and their family, internal or external to the household, with influence on the individual. When we say system, we mean an interacting entity that supports services before, during, or after a pregnancy, ranging from healthcare systems and payers to public services and programs. For providers, we mean an individual with training and expertise who provides care, treatment, and/or advice. And when we say a facility, we mean a physical location where direct care is provided. That can range from small clinics, urgent care facilities, all the way to hospitals with trauma centers. And a community is that grouping based on a shared sense of place or identity, ranging from physical neighborhoods to a community that's based on common interests and shared circumstances. Now, when we look at what was the most contributing factor in each of those categories, for patient and family, it was substance use disorder, access, financial barriers to care, and lack of knowledge. The most common contributing factor at the provider level was lack of care coordination, failure to screen, and inadequate assessment of risk, as well as clinical skill and quality of care, as well as delay. And those were actually the same contributing factors when we look at the facility level. Again, this is important to think about when we're talking about those recommendations. So moving on to the recommendations. When we make our recommendations as a PAMR committee, we make it at the point of intervention. Who can actually make this recommendation come to fruition? So our points of intervention are policymakers, insurance payers, government and public health agencies, healthcare professionals, health systems, and social and local community. Now, we have several pages of recommendations. I will not review all of the recommendations, but regardless of the point of intervention, these priority areas are where there were areas for prevention identified, regardless of who could make the recommendation or who the point of intervention could be. So improving provider screenings for substance use disorder, perinatal and postpartum mood and anxiety disorders, intimate partner violence, and social determinants of health. If you think about when we looked at the contributing factors and we looked at that for facility level as well as providers, failure to screen was one of the contributing factors. Also understanding that accidental overdose was a leading cause of pregnancy-associated deaths, and looking at pregnancy-associated deaths that were related to pregnancy and not related to pregnancy, mental health conditions was a leading contributor in each of those areas. And so we have to improve our ability to screen so that we can better treat all of the things listed here. Improve implementation of evidence-based guidelines for treating substance use disorder. Again, it starts with screening, but after screening, we have to use evidence-based guidelines for treating substance use disorder, specifically thinking about opioid use disorder and using medication-assisted therapy. We have to improve care coordination before, during, and after pregnancy, including support and continued health care during the 4th trimester. Again, looking at contributing factors for providers and at the facility level, care coordination was one of those leading contributing factors. And if we looked at the timing of our deaths, remember for pregnancy-related deaths, 93% occurred after delivery up to 1 year postpartum, with the majority happening in the first 6 weeks. And so again, thinking about the need to have that care coordination and to have access to care during those time periods. We have to address racial and cultural bias across the network of care that serves pregnant and postpartum women. Again, we see disparities by race, we see disparities by social determinants of health, and we can only get to decreasing that disparity gap by addressing racial and cultural bias. We have to identify and address social determinants of health to improve access to care and to decrease disparities in outcomes. Again, as I mentioned earlier, 80% of clinical outcomes are due to social factors. So we have to identify what social factors are barriers for care, for access to care. Looking at our patient family level for contributing factors, we did identify one of the major contributing factors being financial access as a barrier to care. We have to improve patient and family-centered care, including education on the warning signs and individual risk for maternal morbidity and mortality. Again, one of the contributing factors that we identified was lack of knowledge. And that lack of knowledge also is not just communicating this education, but understanding every individual's level of health literacy and ability to understand the education that we are providing as healthcare providers and healthcare systems. And we have to increase and improve harm reduction strategies. This is not just harm reduction for substance use disorder, but harm reduction for things like motor vehicle collisions. We saw that as one of the leading causes of pregnancy-associated but not related deaths during pregnancy. So speaking of harm reduction in many different ways. So how is the Department of Health responding to the findings in this report? So for structure, we didn't mention this at the beginning, but PAMR sits in the Bureau of Family Health, which sits in the Office of Public Health, which sits in the Louisiana Department of Health. And the Office of Public Health has 3 overlapping areas of focus: monitoring maternal outcomes, supporting clinical and systems change, and then policies that support a strong system of care. So looking at maternal outcomes and monitoring those outcomes, in the Bureau of Family Health, we have the Louisiana Pregnancy-Associated Mortality Review, or PAMR, which is what we've been discussing today in our findings. We have the Louisiana Pregnancy Risk Assessment Monitoring System, also known as PRAMS, which looks at data not just after pregnancy, but also during pregnancy, and not just outcomes related to mortality, but outcomes related to other factors that will contribute to maternal morbidity and maternal mortality, such as initiation at pregnancy, the number of visits during pregnancy, as well as breastfeeding. We have the Violence and Injury Prevention Program, again, thinking about homicide being one of our contributing factors to pregnancy-associated but not related deaths, especially during pregnancy. And we have the Louisiana Domestic Abuse Fatality Review, which was established by the legislation a couple of years ago to, again, do a review similar to what we do in PAMR to understand where there are areas of prevention specifically related to domestic abuse. For supporting clinical and systems change, we have the Louisiana Maternal, Infant, and Early Childhood Home Visiting Program, also known as MCV. And this is where we have home visitors that see our patients during pregnancy. Again, thinking about systems change, where we have a way of addressing that barrier to care by bringing care to the patient in their home. We also have the Louisiana Perinatal Quality Collaborative, or the LAPQC. I also serve as the medical director of the LAPQC, and we work with our birthing facilities to implement evidence-based practices based on the AIM bundles, or the Alliance for Innovation on Maternal Health. And that has patient safety bundles that help us to improve readiness, recognition, and prevention and response in our birthing facilities. We have many initiatives going on through the LAPQC, including our Safe Births Initiative, which is addressing obstetric hemorrhage, hypertension, low-risk C-section rate, obstetric sepsis. We have the GIFT, which is our breastfeeding initiative. We have Improving Care for the Substance Exposed Dyad initiative, which is addressing substance use disorder. Again, our leading cause of pregnancy-associated deaths and one of our leading causes of pregnancy-related deaths. And we have the Caregiver Perinatal Depression Screening initiative, which is actually in pediatric practices. So it is recommended by the American Academy of Pediatrics for pediatricians to screen for caregiver perinatal depression at scheduled visits, the 1 month, 2 month, 4 month, and 6 month visit for the newborn. And so we're assisting pediatric practices in doing that, which again, if we think about our contributing factors and how much mental health conditions contributed, this is an important clinical change and a system change to addressing that issue. We also have the Louisiana Mental Health Perinatal Partnership, also known as LAMP. And under LAMP, we have our provider-to-provider consultation line. This is a system and clinical change that allows providers to pick up the phone if we have a patient in our care that is experiencing a mental health situation or issue or substance use, and we don't know exactly where to get them started in terms of treatment. We can pick up the phone, speak to a perinatal mental health specialist that can provide us that advice on how to treat those patients. And then we have also the reproductive health program under the Bureau of Family Health. So thinking about policies that enable strong systems of care, we had our inaugural Maternal Mortality Summit in August 2019, where we brought together many different stakeholders to generate ideas of how we improve maternal morbidity and mortality. Act 497 established the Healthy Moms, Healthy Babies Advisory Council, which generated many recommendations being implemented today. We have Act 182, which established the Louisiana Doula Registry Board. This board has gone through the process of rulemaking to establish the board itself, to establish the criteria for applications, and soon we'll be able to accept applications to be registered in the board for doulas, and doulas that are registered will be able to be eligible for insurance coverage. We have HCR 103, the Maternal Depression Study, as well as HCR 105, the Louisiana Maternal Mental Health Task Force, that generated a lot of recommendations around maternal mental health and how to improve our systems of care, how to improve our clinical quality of care. And a lot of those recommendations are also being implemented in different ways throughout the department. One of the recommendations that was generated from that task force is also led to Act 188, which is the provision for universal screening for perinatal mood disorders in the postpartum period. And this is a provision for obstetric providers, pediatricians, as well as primary care providers to screen for perinatal mood and anxiety disorders in the postpartum period. And SR 131 was a study commission on maternal health and well-being, and again, generated many recommendations that we're implementing in lots of different ways, including through the LAPQC. And SCR 20 was a nursing task force that was established last year. And in this task force, we developed recommendations for how to better incorporate nurses and midwives into maternal care to help improve maternal morbidity and mortality in Louisiana. And finally, we honor the women whose experiences we have attempted to understand and learn from here, as well as their partners, their children, their families, and their communities. We hope that the lessons learned from their deaths will create new pathways to prevention, health, and equity. I thank you for your time. I thank you for all that you are doing to improve maternal morbidity and mortality in Louisiana. Please visit the Partners for Family Health website to view the full report that we've captured here today. Thank you again.